Thank you for joining us at Candlewood House Care Home today for this Dementia Action Week webinar. Candlewood House is TLC Care's new luxury flagship care home in northwest London, which offers outstanding residential nursing and memory care for self-funding residents. As it's Dementia Action Week, we're recording today's webinar from the retro room on our memory care floor at Candlewood House. Before we begin, just a couple of housekeeping rules. Please can you ensure that your mic is on mute? There will be a Q&A session at the end, and just to reconfirm that we will be recording the webinar. Following on from his Parkinson's Awareness talk last month, we're pleased to welcome back Dr. Soumit Singhai, FRCP, to give us an overview of the diagnosis and management of dementia. Dr. Singhai is a consultant geriatrician and physician with over 12 years' experience of working as a substantive consultant in the NHS. His approach to care is very much aligned to TLC Care's approach, inasmuch it's person-centred, with treating what matters to the person to address their needs and goals and improve quality of life. He specialises in dementia and also has a particular interest and expertise in the neuropsychiatric symptoms of dementia, which are the behavioural and psychological problems that people with dementia experience. Dr. Singhai has several memory clinics in the private sector in central London at 25 Harley Street, the Platinum Medical Centre in St John's Wood, and also practices in Hertfordshire. So I'm now going to hand over to Dr. Singhai.
I've got a specialist interest in dementia, and what I'm going to run through this afternoon is an overview of diagnosis and management of dementia. So,
Can we put that on the big screen in the printer?
can you hear okay?
Yes.
Yeah, okay, so I'll be talking a little bit about the epidemiology, the facts and figures involving dementia, then sort of move on to diagnosing dementia, how we do that currently. And then I'll be talking about the different subtypes of dementia and the role of investigations, and then sort of finish off with management. So talking about the pharmacological treatment, about various aspects in management, such as driving, and also talking about the behavioural and psychological symptoms people with dementia face. So some facts and figures. So 1 million people in the UK will have dementia by 2025, which is now only really 4 years away. And this will increase to 2 million by 2050. And this is because of the increasing age of the population. So dementia affects older people. And after the age of 65, the likelihood of developing dementia roughly doubles every 5 years. So as you can imagine, and understand, it's a disease of aging. But having said that, there is also more than 17,000 people under the age of 65 living with dementia in the UK. So the prevalence of dementia is similar in men and women, but Alzheimer's dementia is more common in women, 67% versus 55%, whereas vascular and mixed dementia, which I'll talk about, are more common in men, 31% versus 25%. So some more facts and figures. So currently there's about 540,000 carers for dementia in England, and it's estimated that 1 in 3 people will care for a person with dementia in their lifetime. So half of these people are employed, with 66,000 cutting their working hours, while 50,000 people have quit their jobs. So there's a considerable economic cost associated with the condition, and it's estimated to be about £23 billion yearly. And this figure is predicted to triple by 2040. And this is more than the combined cost of cancer, heart disease, and stroke. So how do we diagnose dementia? So dementia is a clinical syndrome. So essentially it's a failure of the brain, and it affects the higher functions of the brain. So cognitive decline, specifically memory loss alone, is not enough to diagnose dementia. So there needs to be an impact on the daily functioning of the patient and their ability to judge, think, plan, and organise. There's often an associated change in behaviour, such as emotional lability, irritability, apathy, or coarsening of social skills. And this decline must be over time, so months or years, rather than days or weeks, to make a diagnosis of dementia. Because there's some other dementia mimics like delirium and depression, which I'll talk about later on, which are in the differential diagnosis, and their time frame is different. So how do we diagnose dementia? So it's a two-stage process. So step 1 and step 2. So step 1, to make a diagnosis of dementia, we need to differentiate it from other conditions such as depression, delirium. Delirium is a confusional state, an acute confusion due to, for example, an infection such as urinary tract infection, being on certain medications. So it's an acute confusional state that needs to be differentiated. Also, there's the effects of drugs. Drugs can cause sometimes changes in cognition and confusion. And we also need to differentiate it from the changes in memory expected as part of normal aging. So a key feature for diagnosis of dementia is that it should affect a person's daily activities of living, and it should also be progressive, so getting worse over time. The second step, having established that the patient has dementia, the second step is to determine the cause of the dementia. And there's various causes or subtypes to talk about. Alzheimer's disease is the most common cause of dementia.
I don't know how to get that's from coming there.
But there's also vascular dementia and Lewy body dementia, amongst other subtypes. So how do we diagnose dementia? So in practice, what we need to do is to take a careful history. Crucial is the history from involved family, friends, the informant, what we call the collateral history. Collateral information is crucial. We also conduct a physical and mental state examination, which includes an assessment of the cognitive function of the patient. I'll talk about that shortly, and selected investigations. So specialist advice is needed in particular situations when the presentation is atypical and in specific groups of patients, for example, people with learning disabilities. And also specialist advice, and by specialist advice I mean a specialist with a special interest in dementia in the hospital setting, is often needed to diagnose the exact cause of the dementia. So moving on to subtyping the dementia. So subtyping the dementia, so working out the actual cause of the dementia process, is very important in guiding our treatment decisions and in terms of prognosis. Most often subtyping can be arrived by taking a careful history. So in terms of timing of the diagnosis, a timely diagnosis is when the patient wants it or when the carers need it to explain what is going on. So another aspect of diagnosis is that there should be good post-diagnostic support, and this should go hand in hand with the diagnosis. Also, as I mentioned, it's very important to differentiate the different subtypes of dementia, but sometimes in older patients it can be challenging, and sometimes differentiating between vascular and Alzheimer's dementia may not necessarily influence management when patients are more advanced. So this is just a slide to show you what the domains of cognition are. So cognition is a term that applies to memory and thinking, and there's 5 main areas of cognition. So memory, executive functioning, which is one's ability to do tasks, self-directed behavior, so one's ability to plan, sort of adapt to situations, organize things. Attention, obviously, is one's ability to focus or concentrate. Language, so ability to have conversations, understand, communicate. And then visuospatial perception, which is the ability to deal with non-verbal information, for example, judging distances, thinking of objects in 3 dimensions. So broadly speaking, we have 5 main domains of cognition, and in our cognitive assessments, we assess all 5 domains. So I'll talk a little bit more. How does this actually translate to what people experience in terms of the symptoms? So Memory loss, as you're probably aware, is the most commonly known symptom of people with cognitive problems or dementia. And usually it's short-term memory. So it's a difficulty for remembering recent events, names, appointments, and asking the same questions repeatedly. We term this episodic memory or autobiographical memory. So people forget what they've had for breakfast, they'll forget recently held conversations, what they did in the morning or yesterday. So it's very recent memory that's affected. So problems with planning or organizing. So this is what we call executive function. So a person with dementia may not know, for example, in what order to put their clothes on, or the sequences involved in preparing a meal, how to use an appliance like a microwave, which they normally were doing previously fine, or for example, using the television remote or their mobile phone. And then problems with language, for example, a person might find it a struggle to find the right word in a conversation and may pause mid-sentence with family completing their sentences. This is called word difficulties. Visuospatial skills. So as I mentioned, problems judging distances, for example, seeing objects in 3 dimensions. So people with cognitive problems can sometimes get confused about what day or date it is and where they are. And also they can have problems with decreased judgment, poor judgments. They may dress inappropriately, for example, wearing sweater on a very hot day or wearing not many sort of layers on a very cold day. Problems with keeping track of things, for example, a person with dementia may find it difficult to follow a conversation or a television program. So as part of memory, misplacing things, so putting things in unusual places, or put, for example, an iron in the fridge or a wristwatch in a sugar bowl. And then changes in mood or behavior, so they may become more frustrated, irritable, apathetic, withdrawn or anxious. And also changes in personality, so more irritable, more anxious, and having visual hallucinations, for example. So visual hallucinations are when people see things that aren't there, or other symptoms can be believing things that aren't true, like delusions. So in primary care, so what GPs use to support the diagnosis of dementia? So often a person with memory problems will be first seen by the GP, and GPs can use various tests to screen for dementia, and I'll just briefly touch on them. So the most common one is what we call the mini mental state examination. It's a 30-point questionnaire, usually only takes about 5 minutes to perform, and it's a good screening tool. So a GP in a busy surgery can do this test, and if, depending on the score, can identify if there's a problem that needs further specialist input. Then there's the Montreal Cognitive Assessment. So this is a paper-based test shown on the screen there, and it has a bit more sensitivity in picking up people with memory or thinking problems, can pick up more subtle problems, and it's also available in different languages. And again, it's scored out of 30. And if people get marks less than 26, that indicates that there's a problem. And then there's various other tests, which are the abbreviated mental test score, the 6-item cognitive impairment test, and the GP cognition test. So these are all screening tests which are designed really for GPs and busy practices to pick up people with memory problems or thinking problems. So once a patient's been referred to the hospital setting, we have more detailed, comprehensive assessments of their memory and thinking. And the one we most commonly do is called the Addenbrooke Cognitive Assessment, and that usually takes about 25 minutes. So it's scored out of 100, and it goes through the various areas of cognition, as I've mentioned: memory, language, visuospatial function, executive function. And the cutoff is 82. So if the person scores below 82, that suggests that there is a problem with their memory and thinking. And then if that's equivocal or not helpful, just for your information, there is more formal, detailed what we call neuropsychometric assessments undertaken by a clinical neuropsychologist, and this usually is quite involved and takes up to 2 to 3 hours, and is useful when we're sort of investigating the subtype of dementia. It's not routinely done. So when we come to diagnose people with dementia, there's common conditions that can be involved that we need to differentiate from. So the main common conditions are depression. So a person with depression can often present with a similar clinical picture to dementia, and we call this pseudo-dementia. Often also sometimes drugs that have been started in older patients can cause confusion or problems with memory and thinking, and it's always important to look at a patient's medication history. So this is particularly applicable to drugs with what we call a strong anticholinergic activity. So they act on the brain in a certain way, and they can cause confusion in susceptible patients. And examples are tricyclic antidepressants such as amitriptyline, some drugs used for bladder problems such as oxybutynin, and first generation antihistamines. So this should always involve, a review should always involve identifying such drugs and replacing them where possible. Also, strong opioids, so painkillers like morphine, can cause confusion in older patients. And then delirium. So delirium really is an acute confusional state, usually in an older susceptible patient, and it's usually due to an underlying medical cause, such as an infection or an electrolyte abnormality, for example, low salt levels, or being started on an underactive thyroid gland. So various medical problems can cause a delirium. The most common cause of a delirium in older patients is a urinary tract infection, and usually it occurs over hours or a few days. So moving on to the subtypes of dementia. So we have many different causes of dementia, but I've listed here the main sort of subtypes or causes. So by far and away, Alzheimer's disease is the most common cause of dementia, accounting for almost 50 to 75% of cases. Then we have vascular dementia, which is less common. A lot of patients will have both Alzheimer's and vascular, which is what we call mixed dementia. And then dementia with Lewy bodies, which I'll talk about, which is an interesting condition, often not diagnosed and quite different in some ways. And there's also frontotemporal dementia, which tends to affect younger patients, usually in their 50s to 60s, and it usually causes behavioural problems because it affects the frontal part of the brain, the part of our brain which sort of regulates our emotional behaviour. So therefore, patients with this condition will sometimes lose their social inhibition and become quite socially inappropriate in terms of their behaviour. So Alzheimer's dementia. So Alzheimer's disease is the most common cause of dementia, and it's a neurodegenerative process in the brain where brain cells die because of deposition of a particular protein called beta amyloid in certain parts of the brain. And as the condition progresses, the brain shrinks, and certain parts of the brain shrink more relative to the other, particularly what we call the temporal lobes and the parietal lobes and the hippocampal regions, which are involved in memory formation. So it's a condition that's been more common with aging, and the likelihood of developing Alzheimer's disease doubles every 5 years after the age of 65. So people with Alzheimer's dementia, typically the hallmark is short-term memory loss. So this episodic memory or autobiographical memory, which is one's memory of events and experiences that have just happened. For example, conversations, what they've had for breakfast, what they've done the day before, and that's typically affected first. Long-term memory is usually preserved in the early to mid stages. So there's 3 stages of Alzheimer's disease. So early stage, where there's subtle changes in their memory and thinking. So patients can often live alone with some supervision, which often increases as the patient progresses through this stage. The middle stage of Alzheimer's disease, where patients are now needing supervision and help for most of their activities of daily living, and living alone is becoming impossible. And then late stage, where 24-hour care is already there or imminent. Usually median survival, so the average survival of a person from diagnosis with Alzheimer's disease is 8 to 10 years. Vascular dementia. So vascular dementia is a term referred to when there's a problem with blood flow to the brain, which causes brain damage of the brain and affects a person's memory and thinking. And it's usually due to various risk factors, which I'll talk about in the next slide. So often vascular dementia, it coexists with an Alzheimer's process because both are common conditions of aging. And it's often rare to get just pure vascular dementia, unless there's a clear relationship to somebody having a stroke. So with vascular dementia, you tend to get more problems with somebody doing task planning, organizing, what we call executive dysfunction. Memory's impaired, but later, and then you get impairment in all the areas of cognition. So usually the symptoms worsen within 5 to 10 years of diagnosis, and there is this deterioration that can be sudden or stepwise if a patient has a stroke, for example. And usually there's other features that we see, so weakness in one arm or one leg, or increased reflexes, problems with their visual fields, or walking problems. These are all sort of symptoms and features of you can get in a stroke. So how do we manage vascular dementia? So we try to reduce the risk factors, so hypertension, diabetes, atrial fibrillation, which is an irregular heart rhythm, looking at their cholesterol, looking at their smoking, alcohol, and something that's very important is metabolic syndrome, which is syndrome where people have obesity, diabetes, and high blood pressure. Now, most patients with vascular dementia would already have had these factors assessed as part of screening for other health conditions. So an important condition to be aware of is dementia with Lewy bodies. So this is actually quite common. So it ranges from 5 to 22% of all dementia. And the hallmark is this deposition of Lewy bodies, which are collections of protein in cells in the brain, often not recognized in life. So as I've mentioned previously, often these patients are often diagnosed as having Alzheimer's or vascular dementia. And in patients with Lewy body dementia, they experience different problems in their memory and thinking. So they have more problems with attention, so keeping focused or concentrated, more problems with what we call visuospatial function, and then the ability to plan or organize, what we call executive function. Memory is usually preserved early on, but then is affected later on. So there's 4 core clinical features that people with dementia with Lewy bodies experience. So the fluctuation in their cognition, so their memory and thinking really fluctuates from day to day, or even within the same day. And that's a key feature of the condition compared to Alzheimer's, for example, where you don't tend to get that fluctuation. They also have, very interestingly, recurrent visual hallucinations, so very well-formed visual hallucinations, often of people that they know or even strangers, animals such as cats or dogs, and sometimes they have insight, they know it's not real, but other times they can be very much in the process of believing it's true and very frightened by that. It's always important to know whether they're frightened by the visual hallucinations. Another interesting condition is REM, sleep behavior disorder, which is a core feature of dementia with Lewy bodies, and that's when people act out their dreams when they're sleeping. For example, they'll shout or kick or scream in their sleep because they're having a nightmare. And the 4th core clinical feature of a person with Lewy body dementia is that they can have features of Parkinson's, so tremor, stiffness, and slowness of movements. And then there's some supportive clinical features. So they can have repeated falls, repeated unexplained blackouts. They can have quite labile blood pressure because their blood pressure will drop when they stand up, what we call orthostatic or postural hypotension. They can have overactive bladder, so they'll keep wanting to pass urine even though their bladder's not full, and they can get quite constipated. And as I've mentioned, they can also have, as well as visual hallucinations, non-visual hallucinations and delusion, so abnormal thinking, and also a degree of anxiety, low mood and apathy. And it's important because these patients are very sensitive to certain types of antipsychotic, which we shouldn't be giving them. So what are the role of investigations? So blood tests are important because they are needed to rule out any reversible cause of cognitive decline. So we do a blood test panel and we look for things like a thyroid function problem, vitamin deficiency, particularly, for example, B12 or folate. We look at their kidney function. I mean, often they're used as a screening panel just to make sure there's nothing more straightforward underlying a person's memory problems. Now, moving on, we also have what we call imaging tests, and the National Institute of Clinical Excellence, in its guideline on dementia, says that imaging may not always be needed in moderate to severe dementia if the diagnosis is already clear. So the most commonly used form of brain imaging is the MRI, and it looks at, it's a marker of cell loss, neuronal cell loss, so it looks at shrinkage of the brain. We also have functional neuroimaging, which is available these days, and that looks not at the brain structurally, but more from a functional perspective. And the most common types of that are a DAT scan, which is useful at looking at dopamine transporter uptake in the brain. So it's useful for diagnosing people with dementia with Lewy bodies. And then also another important functional neuroimaging scan is the FDG PET. So the FDG PET looks at the glucose metabolism in the brain, and because it looks at glucose metabolism in the brain, it can often pick up changes in the brain 2 or 3 years ahead of what you would see in an MRI, because the conditions that cause dementia are causing cells to die, and the initial thing that happens is that the metabolism in the cell is affected, particularly the glucose metabolism. So an FDG PET will be much more sensitive than an MRI, because once for an MRI to detect changes, the cell needs to die and then the brain needs to shrink. So I'll just show you again. So there's a picture on the bottom right which shows how the brain shrinks in Alzheimer's because of cell death. So MRI, though, although it's not as sensitive as some of the other functional scans I've mentioned, it's the initial tests we do because it's relatively quick to do, it's safe to do, it's relatively cheap, and it's very useful at excluding other causes of memory problems. And so it's the first line test that we do. Disadvantages is that, as I mentioned, insensitive in early disease, and most importantly, it needs a very good neuroradiologist to report it, because a scan is only as good as the person reporting it. So how do we manage dementia? So the National Institute for Clinical Excellence in Healthcare has published a document that highlights different aspects of how we manage dementia. And it's aspects such as involving the actual person in the decision making, it's involving the carers, it's, medicines are one part of it. It's also looking at the non-cognitive symptoms. So there's a whole myriad of important factors: staff training and education, making services available. And this is just a slide to further illustrate that management actually of dementia involves lots of different aspects. So staff training and education, as I've mentioned, support for carers, interventions to help with independence and well-being, advanced care planning, providing information and support to patients and their families. So when should you seek medical help for memory loss? And are there any benefits in early diagnosis? So early diagnosis is beneficial because it helps identify and treat potentially reversible causes of memory loss. For example, thyroid problems, depression, certain vitamin deficiencies. It also provides the affected person and their family with an explanation for symptoms and of what's going on, helps the person and the family to come to terms with things, and enables them to be better equipped to cope as the condition progresses. So it allows them to prepare for the future and plan ahead, get their financial and legal affairs in good order. And it also helps people a better chance to benefit from the available drug therapies that we have and non-drug therapies to really improve their memory and thinking, their cognition, and enhance their quality of life. And identifying the subtype of dementia is particularly important in this regard. So what pharmacological treatments do we have currently? So the main initial first line treatment are called acetylcholinesterase inhibitors. And what they do is they reduce the breakdown of a particular neurotransmitter in the brain called acetylcholine, which is involved in the brain in forming memories. So while we cannot stop the underlying process of cell death, we can combat its effects, and we boost this particular neurotransmitter by giving acetylcholinesterase inhibitors. And these are usually initiated by a specialist. So there's three main types, and I should have mentioned donepezil, rivastigmine, and galantamine, and they all have a similar effect. So they can cause a reduced heart rate, and therefore we always do an ECG before we start treatment or within 2 to 3 weeks of starting treatment. Just some of the side effects to be aware of: dizziness, headache, and nausea are common side effects, and particularly abdominal disturbance and gastrointestinal side effects. But these usually resolve once the patient gets used to it. They are usually safe to prescribe when people have atrial fibrillation, as long as the pulse is over 60. But if a patient has heart block or significant conduction problems, or if the pulse rate is below 60, then we avoid them. So once we started these treatments, we need to review them on a regular basis to assess their benefit and that the patient is tolerating them, and adjust the dosage accordingly. And the guidance is now that we should be continuing these treatments even when the dementia enters the more severe stages, providing they're well tolerated. The most common one we use is called donepezil, and is the first line of treatment for Alzheimer's disease. Rivastigmine is another one, and it's the preferred choice for people with dementia with Lewy Body disease and Parkinson's disease dementia. So the second line drug is memantine. And so the role of memantine is when the acetylcholinesterase inhibitors aren't tolerated because of, for example, cardiac reasons. It's an NMDA receptor antagonist, so it blocks the effect of NMDA, and it blocks the effect of excessive glutamate, which causes cell death. So we can also give it with the acetylcholinesterase inhibitors. And often now the guidance is to give dual therapy with memantine and acetylcholinesterase inhibitors. Some of the side effects to watch out for are nausea, dizziness, body aches, and drowsiness. But again, these do resolve with time once the patient gets used to it, and don't always occur. So another important aspect of looking after and managing people with memory problems and dementia is to look at their other drugs. And this is just a slide which talks about the anticholinergic burden. So a lot of drugs that we use commonly now have some what we call anticholinergic effect. So they actually reduce the levels of acetylcholine in the brain, which you remember I said were involved in memory formation. And this is just a slide. It's very busy, but some of the drugs that can have an anticholinergic effect and therefore cause confusion in susceptible patients are things like amitriptyline, which I've mentioned, oxybutynin, some of the antipsychotics such as clozapine. And from this diagram, you can see that some are in group 3, so which are quite severely causing problems, group 2 and group 1. But even some of the most commonly used drugs, such as furosemide or digoxin, can have negative effects. So it's important to be aware of this. So moving on now, so there's been increasing evidence that there's a number of factors, brain health strategies that we can advise about our patients and families that really do help along with treatment with drugs. So there's an increasing amount of evidence that exercise really is quite neuroprotective, as it stimulates the brain's ability to maintain old connections, make new ones, and slow deterioration in patients with established diagnosis, or even reduce the onset of Alzheimer's and other conditions. Social engagement is very important, so staying socially engaged is very crucial to protect against Alzheimer's disease and dementia in later life. A healthy diet, so eating what we call a healthy Mediterranean diet, can reduce inflammation, protect your neurons, and promote better communication with brain cells, between brain cells. Mental stimulation, so by learning to do new things, can challenge your brain, can strengthen your cognitive skills, and you can be less likely to develop Alzheimer's disease or slow its progression. Sleep's very important, so getting good quality sleep, good duration and quality is important, because it's during sleep that the brain flushes out brain toxins and avoids the buildup of the damaging plaques that you can get in conditions like Alzheimer's. And then stress management. So we know that chronic stress, persistent stress can have negative effects on the brain and actually cause a shrinkage in a key memory area called the hippocampal regions. And therefore, stress reduction techniques are very helpful in slowing the progression of the condition or reducing the risk of developing it. So I want to talk a little bit about the behavioural and psychological symptoms of dementia. So as well as memory and thinking problems, people with dementia can have what we call the behavioural and psychological symptoms of dementia. And these refer to mood problems, psychotic symptoms, and other behavioural problems. So for example, they can become quite apathetic, have low motivation. They can have mood problems like depression or anxiety. And then they can have behavioural problems. They become very agitated, very restless, will start wandering around. They can have an altered sleep-wake cycle, so they sleep during the day but are not at night. They can become aggressive, have problems with socially inappropriate behaviour and become disinhibited, and then have hallucinations where they see things or believe things that aren't true, so delusions. So these symptoms can often be very difficult for the carers to manage, and treatment is really by education and supporting the caregiver. Non-pharmacological treatments are reassuring the patient, reconsidering things, redirecting. So often when a person has these symptoms, it's because of an unmet need. So it's important to sit down with the patient and go through things with them and try and understand why they're behaving in such a way. And then as a final option, we can start various medications. So the benefits of treatment: it improves the quality of life for the patient and the caregiver. It reduces caregiver stress. It can reduce the likelihood of that person moving to a residential home and being independent as long as possible in their own home. And it may improve cognition and function. So it's important to identify these symptoms and treat them. So dementia and driving. So there's a lot of misconceptions about, once a person's had dementia, can they drive? So once a person's been diagnosed with dementia, the diagnosis has to be reported to the DVLA. However, a person may continue to hold a license and drive, and their license is only taken away when they're considered to be unfit to drive. So there's a diagnosis called mild cognitive impairment, which is not automatically reportable to the DVLA. And often when there's a conflict of opinion between the person who wants to drive and family members or the doctor, then an independent driving assessment may be useful. And it's important to understand the only person qualified to say whether a person is safe to drive or not is a registered driving test examiner. And sometimes we have to use a driving assessment in cases where there's a conflict of opinion and where there's different opinions about whether a person's safe to drive. So another important aspect of management is planning ahead. So we should encourage people with a diagnosis of dementia to think about things like lasting power of attorney sooner rather than later. So there's two separate lasting powers of attorney, one for financial and property affairs and one for health and welfare. So the lasting power of attorney can only be done when a person has mental capacity, but it doesn't actually apply until that person loses capacity, and it can be rescinded at any time before that. Also, care planning and end-of-life care planning is important in people with dementia, although sometimes difficult to sort of approach that subject at initial diagnosis, but should be done at some point. And patients should be encouraged to express their wishes and have them incorporated into an advanced care plan and advanced statements. So that concludes my talk. So any questions?
Vicky, you had a question?
Yeah, what is bradykinesia?
Bradykinesia is just a term for slowness of movements.
Okay.
So it's a central core feature of Parkinson's disease or Parkinsonian disorder. So yeah, just slowness of initiating movements.
Okay, thank you.
Did anybody else have any questions? If that's it, then that concludes today's webinar. And again, I'd like to thank Dr. Singhai for his time today and providing such useful insights and an overview for us all. Thank you.
Pleasure, thank you.